All right, today we're diving into an organ that might be small, but wow, does it have a massive clinical impact? The pancreas. If you're on the wards, if you're studying for your exams, this is the high-yield stuff you absolutely need to know about the conditions you are definitely going to see. So let's get right into it.
You guessed it, it's the pancreas. I mean, think about that for a second. When its own super powerful digestive enzymes get activated too early, it kicks off this insane cascade of inflammation and literally starts to destroy itself. This whole process, it's really at the heart of the most common pancreatic problem you'll ever see.
And that process of self-digestion, well, that's acute pancreatitis. And this isn't some rare textbook diagnosis. No way. It's actually the #1 reason people get admitted to the hospital for a GI issue in the entire US. So the bottom line here is you will see this in your practice, probably a lot. You've got to be sharp.
Okay, so let's break down that first encounter you're likely to have, the acute attack. This is where your diagnostic skills get put to the test right from the get-go. So, how do you nail the diagnosis? Well, it all comes down to this classic triad, and here's the key. You only need two of the three. First up, the pain. We're talking that severe, persistent epigastric pain that patients often say feels like it's boring straight through to their back. Second, you check the labs. Is the serum lipase or amylase at least 3 times the upper limit of normal? And third, do you see characteristic findings on imaging? And when we say characteristic findings on imaging, this is exactly what we mean. Take a look at the CT scan. You see all that hazy, kind of blurry stuff in the fat that's surrounding the pancreas? That's what we call fat stranding. And notice how the edges of the pancreas itself aren't sharp and clear? That's peripancreatic edema. These right here are the classic signs of acute inflammation.
So you've made the diagnosis. Great. The very next question is always, why? What caused this? The most common culprits, by a long shot, are biliary disease, gallstones, and alcohol. But you always have to keep a broad differential. Did your patient just have a procedure, maybe an ERCP? You better check their triglyceride levels, because if they're over 1,000, you might have just found your cause. And of course, don't forget to comb through their medication list. Now, one of the biggest complications we worry about in severe pancreatitis is the development of fluid collections, and how they evolve over time is absolutely critical. In the first 4 weeks, we just call them acute collections. Simple enough. But after that 4-week mark, things change. The body starts to build a wall around them. A simple fluid collection can become a pseudocyst, and a collection that's full of dead tissue becomes walled-off necrosis. That 4-week point is the magic number that changes everything. And check this out. These images show that process perfectly. On the left, you've got an acute necrotic collection. See how it's kind of messy, not really well-defined? But now, look at the image on the right taken after 4 weeks. You can literally see that the body has formed this distinct, thick wall to contain all that dead debris. This encapsulation is so important because we really want to wait to intervene until this wall is mature. It just makes draining it so much safer and more effective. So what happens when the pancreas just takes a beating over and over again, or when there's a persistent injury over time? Well, that's when we shift from the acute attack to the aftermath, the long-term consequences of permanent damage, and that's chronic pancreatitis. The biggest difference between these two is really one word: reversibility. Acute pancreatitis is about inflammation that hopefully can resolve. Chronic pancreatitis, that's about irreversible scarring and fibrosis. It's permanent. In an acute attack, the enzymes are through the roof. But in the chronic phase, the pancreas can get so burned out that the enzyme levels might actually be normal. So your entire management approach has to shift. You're no longer just treating the attack. You're managing long-term pain and insufficiency. And this right here, this is the classic textbook sign of that irreversible damage. Those little bright white spots, those are calcifications and stones inside the pancreatic ducts. When you see this on a CT scan, you're basically looking at the tombstone of what used to be healthy pancreatic tissue. It is the hallmark of chronic calcific pancreatitis.
Okay, we need to shift gears now and talk about the diagnoses that you just cannot afford to miss. Pancreatic neoplasms. And this covers both the deadliest cancers and those increasingly common cysts you find by accident.
Let's just start with probably the most sobering statistic in all of GI oncology: a 5-year survival rate of just 9%. Pancreatic ductal adenocarcinoma is incredibly aggressive, and it's almost always diagnosed late, which is exactly why recognizing the warning signs is so critical. So what are those red flags? Well,
Vague abdominal or back pain, unexplained weight loss, and painless jaundice are the classic ones. But I really want you to lock in on this one: new onset diabetes. Especially in a patient over 50, it can be the very first sign that a tumor is brewing, sometimes showing up months before the cancer is ever diagnosed. Now, on the other side of the spectrum, we have the incidental pancreatic cyst. With more and more people getting CTs and MRIs, we're finding these things all the time. And as this quote says, they cause a ton of anxiety for the patient and for you. The big million-dollar question is always, which ones do we actually need to worry about? So here's your practical checklist of what to look for. Does it involve the main pancreatic duct? Is it big, say over 3 centimeters? Can you see a solid chunk or a nodule growing inside it? These are the features that should really make your ears perk up. They signal a higher risk of turning into cancer and mean you have to pause and investigate further.
Let's look at a really clear example of a high-risk lesion. This is an MRCP image showing what we call a main duct IPMN. See where the arrows are pointing? That whole main duct in the tail of the pancreas is massively dilated and just filled with cysts. This is not a subtle finding, and it carries a really high risk of becoming malignant, which often means it needs to come out. Okay, we've covered a lot. Let's boil it all down into 4 super high-yield clinical pearls that you can take with you to the wards tomorrow. Pearl number 1, remember, gallstones are the #1 cause of acute pancreatitis. So your first imaging step shouldn't be a fancy CT scan. It should be a simple, cheap, non-invasive transabdominal ultrasound to look for stones in the gallbladder. It's effective, and it answers the most likely question first. Okay, this one is huge, and it's a super common mistake. A lipase of 10,000 is not necessarily worse than a lipase of 1,000. The absolute number is for making the diagnosis, not for prognosis. Severity is all about clinical signs. Is there organ failure? Is there systemic inflammation? It's not about the lab value. So please don't keep rechecking the enzymes every day.
We've said it once, but it's so important we're going to say it again. If you have an older patient, say over 50, with no real risk factors, who all of a sudden develops diabetes, you have to have pancreatic cancer on your differential. It is a critical, can't-miss red flag.
And finally, for all those incidental cysts that cause so much stress, remember, the vast majority of them are benign. Your job is to be a good detective. Look for those high-risk features we talked about, and then reassure the majority of your patients while making sure the select few with worrisome signs get further evaluation. So I want to leave you with this question. The central challenge with pancreatic disease, especially cancer, is that it's a silent killer. We find it too late. So as we get better at treating all the complications, the real question for the future is, how do we find it earlier? What's going to be the next frontier, the breakthroughs in screening and early detection that finally moves that dismal survival curve? That's really the challenge for all of us. Thanks for joining this explainer.